Hi all, I am Dr. S. Prakash Babu, Associate Professor of Emergency Medicine at SWIMS Tirupati, and also the Chief Examiner for the SACTUM mock examination. In this lecture, I am going to talk to you about how to approach a written ASCII station. A written ASCII station is for about 40 marks as per the NMC guidelines. I am going to tell you about a practical strategy for a structured and high scoring answers. As you see, most of the students struggle in written ASCIIs. It's not because they lack knowledge, they know the topic, but just they cannot structure the answer. They write too much theory, they miss critical emergency priorities, they panic under time pressure, and fail to write in a high scoring format. ASCII rewards structured clinical thinking, not just random knowledge dumping into the paper. So, by the end of this lecture, I expect you to understand how to write a written ASCII station, how it is constructed, read the station stem efficiently, apply a stepwise framework to any case, write exam smart answers that score, and avoid common mistakes that cost you marks. The session plan for this lecture include understanding the ASCII station for 10 minutes, universal answering framework for 15 minutes, how examiners think for 5 minutes, worked examples for 15 minutes, common mistakes that student makes for 10 minutes, summary and take home points for 5 minutes. So what exactly is the written ASCII station? What exactly is the examiner expecting you to write in a written ASCII station? It's a short clinical problem solving task that tests your recognition, your prioritization, which is most important in the emergency department, your structured reasoning, safe management, and organized communication of whatever information that you have is the objective of the ASCII station. So, in an ASCII station, you are supposed to recognize important clues, clinical prioritization, structured reasoning, safe management planning, and ability to communicate in an organized way. Remember that an ASCII station is not an essay, it's a clinical response under time pressure. There are certain common types of ASCII stations: assessment based, common types of written ASCII stations are assessment based questions, diagnosis based questions, investigation based questions, management based questions, and mixed stations. Assessment based questions include initial approach to a patient, diagnosis based questions, likely diagnosis or differentials. When you're thinking of differentials, an emergency physician is expected to think about the most life threatening or critical diagnosis at first, and then move on to the urgent diagnosis, and then finally non urgent diagnosis. Investigation based questions: what test would be ordered and why? Most commonly, it would be what would be the best test that you need to answer. Management based questions: they ask you to outline the emergency treatment. Some mixed stations will be there. In part A of the question, they might ask you how to approach a patient, initial approach. Then they follow it the likely diagnosis or differential diagnosis and outline the emergency management. These are the common types of written ASCII stations. So the first rule: always, whether it is a theory, it is practical, or it is an ASCII station, read the question properly. Find out answers for these 5 questions: who is the patient, where is the patient, how sick is the patient, and what exactly the examiner is asking you to do. Do not answer the topic, answer the task. Next comes how to decode a station stem. So I am presenting you an example: a 5-year-old child with fever and breathing difficulty, presented with a respiratory rate of 48 per minute and a heart rate of 140 per minute with an SpO of 88% on room air. So what do you see from here? What are the red flags? As you are right, The red flags include the tachypnea and the hypoxia. Patient clues that you need to check in the question include age, what symptoms the patient has presented to you, the duration of the symptoms, severity clues, vital signs, mental status, and of course the saturation. In the clinical context, ED, trauma, or pediatric or toxicology room where the patient is exactly present. Hidden red flags include shock, hypoxia, altered sensorium, and seizures. There are certain verbs that tell you how to answer and what you need to answer. When the examiner asks you to list, you are supposed to write in bullet points only. Just present a list, don't go into the details. If the examiner asks you to outline, a stepwise structured approach has to be followed. If the examiner asks you to describe, a brief explanation can be given. If the patient examiner is asking you to interpret, state the finding and what exactly it means, how it affects the clinical management of the patient in the ED or during shifting. If the examiner asks you to discuss, write a short, balanced expansion of what has been present and what you wanted to answer. Many students lose marks just because they answer in the wrong format. So, coming to the universal written ASCII framework in emergency department, you are supposed to address everything in ABCDE format: airway, breathing, circulation, disability, and exposure with environmental control. Then move on to the differential diagnosis. After differential diagnosis, what investigations you are going to order. When you are talking about investigations, you are supposed to write in a format such that bedside investigations are written first, followed by the laboratory investigations, and then the imaging investigations. Again, you have to differentiate between what is the investigation that is most probably going to give you a diagnosis or rule out other diagnosis. That comes first, and then your other investigations which are supportive to the main investigation will be listed out. Coming to the management, the management part again, supportive management comes later, the life saving interventions come first, and then finally you move on to the disposition of the patient. This framework works for most emergency based rescue stations, and if you follow this format, you will have a clear idea and score very high. So I'm going to go a stepwise approach. Step one, start with the clinical big picture. Is the patient sick or stable? Does this patient need a resuscitation first before attempting to diagnose and to definitive management institution? Is there any immediate life threatening illness for the patient? Because ASCII examiners want to see whether you can prioritize danger first. They don't see whether you have the knowledge or not. It's your prioritization that matters most in the ASCIIs. Use ABCDE every time. So airway, whether it is patient, patent or obstructed, breathing, look at the respiratory rate, the effort of the breathing, which is commonly missed by residents, and look at the saturation of the patient. Coming to circulation, pulse, BP, and perfusion are checked. Perfusion is very, very important. None of these values replace the other. Disability, you can either do a Glasgow coma scaling or you can go for AVPU scaling. Check the pupils and check the blood glucose. Then the exposure, fever, trauma, rash, dehydration are checked during exposure. If you are confused in a written ASCII, go back to your ABCDEs. Not just in ASCIIs, in any emergency situation, any emergency exam, if you go back to your ABCDs, that is your basics, you will get the answer. Step 3 is focus on relevant clinical information. Look for the following in the ASCII STEM: history, onset, duration, and associated symptoms, relevant past history, drugs, and allergies. The examination, specific systemic findings, signs of severity and deterioration are the things that you need to look in the clinical examination. Do not write full textbook history unless is asked. Write just the history that is there in the OSCE stem. Step 4 includes writing a smart differential diagnosis. The most likely diagnosis first. Add two important alternatives to the most likely diagnosis. Most likely diagnosis means whatever the patient is undergoing right now, let it be a hypotension, bradycardia, shock, any abnormality that is the patient is having should fit into a single diagnosis. That becomes your mostly diagnosis. That should come first, and then you add two important alternatives, and then include at least one dangerous possibility or a critical illness. Keep them clinically feasible and prioritized. A good OSCE differential is relevant, prioritized, and safe. Then go to the investigations. As I already told, the investigation have to be targeted. So bedside investigations first, like SpO2, glucose, ECG, ABG, and if you have start lab, the start investigations can be done here. Then you will move on to the laboratory investigations where you look at the complete blood picture, electrolytes, troponin, lactates, so forth, so on. And then you go on to imaging like X-ray, ultrasound, and CT. Whatever fits the situation, you have to proceed with that investigation. Do not write a shopping list. Investigation should fit the case. Step 6 is writing the management in the correct order. Again, as I told earlier, the immediate things, the life-saving things should come first, like oxygen support, monitoring, IV access. So the patient needs intubation, intubate the patient and put him on mechanical ventilator. Then after you saved the life of the patient, then you proceed with your diagnosis and specific management. Specific management is nothing but the disease targeted treatment. And then comes the supportive management like antipyretics, analgesia, nebulization, etc. And then finally a definitive care like transfer to ICU or transfer to operation theater, thrombolysis, or referral to another center if you don't have the facilities come next. In emergency OSCEs, management must be prioritized, not merely listed. Step 7 is never forget disposition, discharge with advice or observation or ward admission, or if the patient needs intensive care unit or pediatric intensive care unit admission, or if the patient is in need of a surgery or shifting to cath lab or referral when the services are not available. This should never be forgotten in any exam format by the emergency medicine residents. A student writes disposition appears clinically complete and safe. So that is about how you write the OSCE. Now I'm going to reveal the secrets, what and how the examiners usually think. So what else you marks? Your structuring, your prioritization, how safely you are managing the patient, the completeness of management, and the clinical judgment will fetch you marks. Whereas writing randomly, missing emergencies, writing theory in the OSCEs, no ABCD approach, no oxygen in hypoxia, no disposition will make you lose marks. Structured average answers often outscore unstructured brilliant answers. Finally, we'll end with a worked out example. Pediatric respiratory distress patient. The same example I have given initially, I'm repeating. A 5-year-old child presents with fever and difficulty in breathing. Respiratory rate is 48 per minute. Heart rate is 140 per minute. And SpO2 is 88% on room. Task 1 is initial assessment. Task 2 that you need to write is differential diagnosis for this case. And task 3 is how you are going to manage this child. So how to write a structured answer? In the initial assessment, you use a pediatric assessment triangle. So the child is sick, child is hypoxic. You follow the ABCD approach. Yes, child is having tachypnea, tachycardia. What differentials do you think of now? Yes, because of the respiratory distress, it is a severe pneumonia case, or it could be a bronchiolitis, or a 5-year-old child. Acute asthma is the least likely diagnosis, but still you can add on. Management includes the initial management like oxygen IV access monitoring. Antibiotics are the mainstay of treatment, and nebulization if the wheeze is present. And finally, you need to end with disposition, admit the patient, escalation if worsening. The answer should be short, structured, which gives you a high scoring opportunity. So example 2, a patient with adult with chest pain with shock, a 60-year-old man present with severe chest pain and sweating. His BP is recorded as 90 over 60 millimeters of mercury with a heart rate of 120 per. So again, the task is initial assessment, differential diagnosis, and management. In ABCDE, the airway looks patent, breathing is other, and circulation suggests shock. Differential include most common is acute myocardial infarction, could be a cardiogenic shock, and a pulmonary embolism. Management, oxygen if hypoxic, ECG immediately, IV access and monitoring. Begin ACS protocol as appropriate. Disposition includes shifting to cath lab or cardiac ICU and following up with definitive care. What are the common mistakes that cost you marks? I mean, I've told some of these already. No theory. If you write long theory answers, you end up answering only half the questions. Half the questions will be left out and you lose marks there. If you miss ABCDE, you're showing the examiner that you don't have a sense of emergency medicine. Ignoring abnormal vital signs. I don't have to tell you, it's a lacuna by itself. Listing too many irrelevant investigations doesn't look good when you do in the clinics also. Prioritization is the heart of emergency medicine. If you don't prioritize, if you don't triage, there's no point being an emergency crisis. You forget disposition, patient ends up in emergency without a definitive care. And if you don't take emergency actions, you might lose patient. What the examiner is asking? Examiner is asking, can you think safely and clearly? So finally coming to the management of time. In the first minute, read and decode the stem. In 2 to 4 minutes, write a structured answer. And in the fifth minute, review for any missed critical points. As an exam tip, write headings first, then fill them quickly. The one formula to remember to score high is initial assessment in the form of ABCDE, proceed to differential diagnosis, initial management, a definitive management, and finally disposition. Start with ABCDE, prioritize life threats, use headings and bullets, mention critical interventions clearly, always state what happens next, which is called disposition. This is an ASCII answer template that you can follow. Initial impression, ABCDE, focused history or examination, differential diagnosis, investigations, management, and disposition. This is a reusable skeleton students should memorize. Bad answer versus good answer. A bad answer includes long paragraphs, there is no ABCD, there is no triaging, random tests are ordered, tests are not targeted to the patient, no disposition is written. The same time, a good answer is has a clear headings, has critical points written down, ABCD approach has been followed, a triaging has been done, investigations are targeted, not random, whatever is available is not done, and you have written down a safe disposition. Thank you. A good written ASCII answer is not long, it is logical, safe, and structured.